89 വയസ്സായി. കഴിഞ്ഞ കൊല്ലം ക്യാൻസറും വന്നു, കീമോതെറാപ്പിയും റേഡിയോതെറാപ്പി എല്ലാം കഴിഞ്ഞിരിക്കുകയാണ്. അപ്പോൾ എന്നോട് തന്നെ ചോദിക്കണം എൻ്റെ ഹെൽത്തിൻ്റെ സീക്രട്ട് എന്താണെന്ന്. സോ വെൽ, I consider myself to be healthy. So, to be honest, and I thank Arun for giving me this opportunity. And the reason is that I have been physically active from college days. Before medical college, I was not very physically active because I was a boy, and my father was responsible for that. He wouldn't send me out to play anything at all. When I joined medical college, I was free. I played every game possible. But finally settled on basketball as a game in spite of my short stature. And from the short stature, I developed a long shot that helped me in my life also. Then I started running. The reason for why I started running, biology lab, I had the maximum. Even being the little fellow, I had more than the others. So I said, maybe I should start running. So I started running, and I started the sprint events, 100 meters. I was not fast enough. I did a long distance, 5,000 meter. I came second only. But then I had a chance to be a part of the 400 meter relay team. And in 1967, I was the athletic. They made me the athletic captain of the college team, not because of my athletic prowess, because everybody liked me. I was a nice guy, so so they liked me. They made me the captain. And surprise, we won the university championship that year in 1967. And I was the athletic captain, and I was member of the 400 meter relay team. And let me tell you, I was the slowest member of the 400 quartet. But even then, I got a gold medal because I was part of the gold medal winning team. And I lifted the trophy for the university championship. But one of the things I did is that I never gave up running. And when I went to Trivandrum for MS, I ran, but I played basketball mostly. And when I went to England also, I kept on running and I played basketball. In spite of my little size, I played for the Birmingham City team with those guys. They were kind enough. I went there, they included me in the team. But one of the things, I never gave up running. And when I was in the Gulf, I kept on running. I was in Muscat for 26 years. We had a running group called Muscat Road Runners. And we all practiced for the marathon, and we ran the Dubai. So I practiced for the long run, the marathon. 42 kilometers, and I used to run marathons and half marathons, and I ran the Dubai marathon. So when I came back to India also, I kept running here until I became sick with lymphoma, and I had to take a gap, a hiatus, and I underwent treatment. And not only did I keep running, I worked out in the gym also when I was in the Gulf. So I was fairly fit. Running marathons and working out in gym is, it helps you. After, good morning, sir. And after I became fairly well enough, I started running slowly. I run slowly now, but I do some workout in the gym, and I think I keep my muscle mass. The basic thing is that you have to be fit and keep muscle mass. Rather, you should, as I was sitting there and talking to Philippine and Dr. Mohan Varghese, he was telling me that the fat doesn't carry you, you carry the fat. It is the muscle which carries you. So make sure that you have fat rather than muscle. Cut down carbohydrate, do not proteins and vegetables. That is my message. Thank you. Thank you.
It is always great to see how Sir has his lunch. So I always be with our John Sir for the lunch time. So it's an inspiration for us to have a healthy diet. Okay, so it's time. So we'll start with a prayer.
Shall we pray? പിതാവിനും പുത്രനും പരിശുദ്ധഹായ്ക്കും സ്തുതി ആദ്യം എന്നേക്കും തന്നെ ആമേൻ. പരിശുദ്ധനായ ദൈവമേ, സ്വർഗ്ഗസ്ഥ പിതാവേ, ഈ മാസത്തിൻ്റെ 2ാമത്തെ വ്യാഴാഴ്ച വീണ്ടും ഞങ്ങൾക്ക് ഈ തിയേറ്ററിൽ കൂടുവാൻ തക്കൊണ്ട് ദൈവം ഞങ്ങളെ സഹായിച്ചു. ഇന്ന് ഞങ്ങൾ കേൾക്കുവാൻ പോകുന്ന കാര്യങ്ങൾ, ഡിസ്കസ് ചെയ്യാൻ പോകുന്ന കാര്യങ്ങൾ, അത് ഞങ്ങൾക്കും ഞങ്ങളുടെ ഹോസ്പിറ്റലിനും വരുന്ന തലമുറയ്ക്കൊക്കെ ഒരു അനുഗ്രഹമായി തീരുവാൻ സഹായിക്കണമെന്ന് പ്രാർത്ഥിക്കുന്നു. ഇതുവരെയും അതങ്ങനെയായിരുന്നു. അത് വളരെയധികം പ്രയോജനപ്പെട്ടു. ഇന്നും ഞങ്ങൾ അതിനുവേണ്ടി കാത്തിരിക്കുന്നു. അതിൽ പാർട്ടിസിപ്പേറ്റ് ചെയ്യുന്നവരെ, ലീഡ് ചെയ്യുന്നവരെ ഒക്കെയും അനുഗ്രഹിക്കുകയും അങ്ങ് സഹായിക്കുകയും ചെയ്താട്ടെ. പ്രാർത്ഥനയുടേതായ സ്തോത്രം. ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ. ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Welcome everyone. This is the third CPC session, and we are very grateful to the Department of General Medicine for giving the case and for volunteering for the CPC. And I invite Dr. Manchu to moderate the session and to invite the faculties.
Good morning, BCMCH family. Today we have the distinct privilege of inviting Dr. Thomas Jacob, Associate Professor, Department of General Medicine, for presenting an interesting case. After his initial training in KMC Manipal, sir has worked in various prestigious institutes like CMC Ludhiana and various mission hospitals across North India and Africa. Sir's vast clinical experience shall provide us with diverse perspectives and help us in unraveling this medical mystery. We welcome sir for presenting this case.
We invite SK Matthew sir, Mohan sir, Prashant sir, Joseph John sir.
Good morning, my respected seniors, my dear colleagues and students. I want to thank the Department of Medicine for this opportunity to take up this challenge. CPCs are usually very challenging. As my dear friend Danny said, boss, whatever your diagnosis is going to be wrong. So the end result is not that we get the diagnosis, it's the workup. At least I keep consoling myself. So anyway, we'll see how this case goes, and we'll see how to take it step by step and come to some level of differential diagnosis. Okay, so starting with the case, we have a history. This is a 77-year-old gentleman. He's a diagnosed patient of multiple myeloma elsewhere, and this is 7 years ago, and he's on thalidomide therapy. Now, 2 weeks prior to admission to BCMCH in an outside hospital, his first admission was for a stroke to a neurological unit, and he was treated and discharged. Soon afterwards, he's readmitted under general medicine in the same hospital with fever and chills. And he's initiated on piperacillin-tazobactam. Few days later, the urine culture sensitivity comes as multi-drug resistant E. coli, which is sensitive only to colistin. The blood culture and sensitivity grows coagulase negative staph. The antibiotics is escalated to polymyxin. We can assume that this is polymyxin B, and he receives it for 5 days. But he continues to have fever. The antibiotic is changed to ceftazidime-tazobactam. He receives 2 doses, and that's when he is referred to our hospital with persistent fever. This is his drugs that he has been taking. You'll notice in addition to thalidomide, he's also on dexamethasone 4 milligrams, 3 tablets in the morning and 2 in the evening on Sundays. On admission to BCMCH, his pulse is 86. His BP is just 80 by 60, but it's fluid responsive, and we don't see him having hypotension after that. His saturation is 98. His general examination, systemic examination is unremarkable. He also has a urinary catheter in situ, which is changed in the ER. So he's admitted to our hospital with the provisional diagnosis of partially treated UTI and multiple myeloma. Now these are his labs on admission to our hospital. He has a mild anemia, but the other counts are fine. He has a raised creatinine. We don't have his weight or the GFR. CRP is elevated. Procal is elevated. He's not a known diabetic, but his HbA1c is on the higher side. And there's low albumin and mild transaminitis. So at admission here, his diagnosis was partially treated MDR E. coli, catheter associated probably. Now, if it is polymyxin B, we need to question the antibiotic selection there because it's an MDR E. coli UTI. And probably polymyxin B is a poor choice because it's poorly excreted in the urine. And the colistin is the preferred drug. Probably it was because of the AKI that this was not chosen. So still the first diagnosis at this stage would be a partially treated MDR. What about the Cons infection? We don't know if there was a central line. We don't know how many sites the culture was taken for. Could it be a multiple myeloma relapse with fever setting in? We don't have any history of any bone pains or there's no hypercalcemia. Could it be a thalidomide induced adverse effect or toxicity? Sometimes thalidomide can cause fever. And as part of toxicity, also patients are known to have fever, neuropathy, among other things. Could it be a drug fever? Now, of course, down the line, you also have to think, could it be one of the common acute undifferentiated fevers? Although, we don't have any history of travel, no outdoor activity, no family history of contact with anyone with fever. There's no history of any reduced platelet counts. So we put that lower down in the order. So the initial course at BCMCH, the patient continued to be febrile after admission. At admission, thalidomide was withheld, and he was initiated on piperacillin tazobactam ER, but that was quickly escalated to colistin sulbactam based on the outside culture reports. And of course, before that, we send our own blood and urine culture. Urine grew Candida tropicalis, but we have to keep in mind that this patient has been on catheter for quite a long time. Blood culture was sterile. Patient had a severe right shoulder pain, and we got an ortho consultation, and that showed a degenerative rotator cuff arthropathy and acetabolization of the humeral head. Day 5 in hospital, he is still febrile. There is worsening renal functions, and so rightly so the colistin was stopped and switched over to ceftazidime, avibactam, and aztreonam. The hematology department reviewed the patient and the diagnosis of multiple myeloma, and the testing showed just a faint M band, and the kappa lambda ratio was maintained, and IgG was decreased. So it looks like it's probably a multiple myeloma in remission, and so thalidomide was withheld. Day 6 and 7, patient continues to be febrile. He's noticed to have an intermittent cough. The sputum is sent for AFB TB PCR, which turns out to be negative. This is the chest X-ray that is there, that was given. He was started on levofloxacin, but he continued to be febrile. The repeat blood cultures here came out to be sterile. So on day 8, there's persisting fever, and this is in view of the persisting fever that has been going on, which started probably 10 to 14 days prior to hospital admission, and now going on for further 8 days or so. The team decided to go ahead with the PET-CT. Now the PET-CT showed an FDG avid soft tissue lesion in the left testis. And the standard uptake value is quite high, 14.92. In addition, there is a lesion in the left serratus anterior muscle with a standard uptake value of 5.5. What is also noticed is that there is diffuse uptake in the entire bone marrow, the mediastinal, retroperitoneal, and abdominal lymph nodes. And there's miliary nodules in both the lungs. The patient had only a discomfort in the scrotum. The pain that was referred, it was mainly a discomfort. I just clarified this with the team that was treating. He was noticed to have skin erosions and excoriation in the posterior aspect of the scrotum and gluteal region, but there was no tenderness as such. Now, the ultrasound of the scrotum that was done showed ill-defined heterogeneous, predominantly hypoechoic areas with internal vascularities in the left testis. So subsequently, seeing the testicular mass, the alpha-fetoprotein, beta-HCG were done, they came as normal. LDH was raised. Patient was transferred to surgical oncology, and a high orchidectomy was done after stopping aspirin. However, patient continued to have intermittent fever. Now, gradually, patient developed alteration of sensorium, and he was advised to have an MRI, CSF study, and EEG was planned. However, the relatives were not willing for CSF study. The MRI is not available to me. The EEG showed mild degree of generalized non-specific disturbance of electric function. As per neurology advice, antiepileptics were initiated. Patient continued to have persisting fever. Repeat urine culture now showed MDR Klebsiella pneumonia. Chest X-ray. Now on the chest X-ray, we can see that there's a left lower zone non-homogeneous opacity developing. And he was initiated on colistin and cefoperazone sulbactam. Now, these are the overview of the reports that we have. You can see that the counts, the TLC count and the platelets remain relatively stable. And the CRP has been on the higher side, but gradually coming down. He's got low iron, TIBC and TSATs. Is that iron deficiency or is it some inflammation that is going on? And we see the transaminitis also gradually comes down. And these are his other test reports. Over a period of time, so important to note, the viral markers are negative. The sputum, there is no AFB, PCR is negative, H1N1 is negative. There is no growth in the sputum culture sensitivity. Urine just keeps growing, Candida tropicalis. The ACE levels are 52. And that's finally what we have, the MDR Klebsiella. Procal levels also seem to be coming down, this as along with the CRP, but patient persists to have fever. Finally, a biopsy report was reviewed of the testicular lesion of the orchidectomy sample, and further diagnostic test was performed. This patient was initiated on therapy and his sensorium gradually improved and he became afebrile. Patient was discharged from the hospital, but he continues to have decreased verbal output and is dependent on others. So just to summarize the course in BCMCH. So he came with a history of MDR E. coli, and he was put on colistin for 5 days. In view of worsening AKI, he shifted over to ceftazidime avibactam with aztreonam. He has intermittent cough. The sputum AFB and TB PCR is negative. He's added on levofloxacin, but he continues to be febrile. So in view of persistent fever, a PET scan is done, a PET CT. And we see this lesion in the testis, and ultrasound scrotum is done, and that shows a testicular lesion as well. A high orchidectomy is done. Patient develops altered sensorium. MRI and EEG is done. He's put on antiepileptics. Continues to have cough. He's developed some infiltrates on the chest X-ray. He shifted over to colistin and cefoperazone sulbactam, but he's still persisting to have fever. And the biopsy, we see that finally biopsy result comes, a treatment is initiated, and he becomes afebrile. So this is the picture, this is the case that we have before us. And so what do we make out of it? How do we handle it? So as we see the overall now in his whole hospital stay, it's gone over 5 weeks, and he's been having persistent fever for over 5 weeks. And we could call this a fever of unknown origin. Now, if you look at our literature, students, these are the causes of fever of unknown origin. We have all these causes. Now, we can't expect the patient to have all these tests done to rule out. So we need to have a plan to find out what is the possible causes of fever. Now, if you look at the classification, we have infectious disease. And as the fever prolongs, we start considering these other things like connective tissue disorders, malignancies, and the miscellaneous causes of fever. So how do we approach a FUO? I've modified this from Harrison's Principles of Internal Medicine. So if you have a fever more than 101 for more than 3 weeks, again, the main thing is to have a diligent search for PDCs. What do we mean by PDCs? PDCs are potential diagnostic clues. Potential diagnostic clues. Potential diagnostic clues are defined as all localizing symptoms, signs, and abnormalities that potentially point towards a diagnosis. So throughout our workup, we need to keep looking for potential diagnostic clues. History and examination is of utmost importance in dealing with patients with FUO. We might need to stop or replace medications if we are suspicious of a drug fever. And then we have this extensive panel of testing that we have already done in this patient. That includes cultures and any other test that is directed by our history and examination. Now, after doing your history examination and your testing, if you have some potential diagnostic clues, then you need to work along that and get a diagnostic test done. And this might reveal a diagnosis, or it might not reveal a diagnosis. Or maybe it might be a misleading potential diagnostic clue. So if it is absent or misleading, then the next step is that we have to go ahead with an FDG PET CT, as was done in this patient. And there we can confirm an abnormality and go ahead with a biopsy and culture. Or maybe there's no abnormality, and that is where you need to persist in looking for PDCs. You need to keep examining, you need to keep taking new histories, because something might crop up along the way. And that's how we need to go at it at working a case of FUO. Now, what about our case? In our potential search for potential diagnostic clues. Now, we have a lot of things happening around. We have this history of multiple myeloma. We were considering, is it a relapse? Was it thalidomide-induced toxicity or adverse effect? Was it the MDR E. coli UTI? And later the MDR Klebsiella, which was treated but did not seem to be lowering the fever. Was it drug fever? But we see that drugs have been changed multiple times, but the fever still persists. Was it the lower respiratory tract infection? Again, the fever persisted. Was it the Candida tropicalis? The catheters were changed, and there was nothing to suggest that, there were no symptoms to suggest that this is a Candida tropicalis UTI. Are we missing the elephant in the room? And that's what probably was revealed by the PET and the ultrasound. So that's the PET revealed that there was a testicular lesion. And not just a testicular lesion, but we see there's retroperitoneal nodes, abdominal nodes, mediastinal nodes, there's bone marrow involvement likely, there's miliary lung nodules, and then down the line we get a CNS involvement as well. So how do we go forward from here? What are the DDs that we can have? So we have fever for more than 5 weeks. Now we have detected this testicular mass, lymph nodes, florid lymph nodes, lung involvement, CNS involvement, and probably bone marrow involvement. So how do we go ahead? So when we are considering the testicular lesions, one thing we think about, crosses our mind, should be primary testicular malignancies, especially in the setting of lymph nodes, lung involvement, bone marrow involvement. Malignancies definitely cross our mind. And considering the age of the patient, 77 years. Now, when you think about malignancies, the most common malignancy is germ cell tumors. We have seminoma, we have non-seminomas, embryonal yolk sac tumors, choriocarcinoma, and teratoma. And we have mixed germ cell tumors. Now, the thing is, most of these are much more commoner in the younger age group. We don't usually see them in someone who is 77 years. They're usually below the year of 50, and some of them in their 40s, 30s, or even in their adolescence. There's one variant, spermatocytic seminoma, which can happen at an older age group. But when you think about somebody in his 70s, we think about primary testicular lymphoma. That's the most common tumor in someone above the age of 60. And among this, diffuse large B cell accounts for 80 to 90% of the lymphomas that are seen. The others are mantle, Burkitt's, and Malt. Then we can have your sex cord stromal tumors, which are much more rarer. They're usually benign. Only 5 of them turn out to be malignant. Your Leydig cell and your Sartori cell tumor. So they are much more rarer. The other things, what we need to consider, metastasis is extremely rare. So metastasis to the testis is an extremely rare phenomenon. You could have it from a melanoma, or you could have it from a prostate or from a renal cell. But it's extremely rare. The other thing to consider is, with view of fever, and these is disseminated infections. And of course, in our setting, we always think about tuberculosis, disseminated tuberculosis. HIV has been ruled out. Brucellosis is the other thing that we need to keep in mind. Cytomegalovirus, we are keeping in mind also that this patient has been on steroids for a long time. For 7 years, he's been on steroids. Cytomegalovirus, melioidosis, Mycobacterium avium complex can have all these symptoms, and rarely it can also involve the CNS. Nocardiosis, histoplasmosis, coccidioidomycosis, these all need to be kept in mind. Probably tuberculosis would be high up on our list. Because the patient is immunocompromised, we need to consider these others as well. However, going on for 5 weeks without much deterioration, we need to keep that in mind also. We need to question it. Can it really be that? Then we have also the non-infectious inflammatory diseases, your connective tissue disorders, your vasculitis. Sarcoidosis, we need to keep sarcoidosis in mind, which could have a very similar picture. Polyarthritis nodosa, SLE, rheumatoid arthritis can all have lymphadenopathy, undiagnosed fever, CNS involvement, lung involvement. Testicular involvement can be there. It's much more rarer though. However, if you were to look at the criteria wise, you wouldn't see that they would be fitting probably into SLE or rheumatoid arthritis. And polyarthritis nodosa also in the age is much more higher for a PAN. Local infections, we would like to keep it lower down, orchitis or epidermoorchitis or abscess formation, because this patient, as per his PET report, seems to be having something which is much more florid and disseminated. So after this, narrowing it down, what would be my top 5 considerations? My first consideration would be a primary testicular lymphoma. What is in favor of it? Most common testicular malignancy above the age of 60. So germ cell tumors, overall it is the bigger testicular malignancy, but if you're looking at someone who is above the age of 60, we have to consider lymphoma as the first diagnosis. And of this, diffuse B cell type is the most common. There is a high FDG uptake in the testis. So there was a high SUV score. However, at this point of time, we can't use the SUV score is not used to differentiate between a malignancy and an infection. The testicular lymphoma, 60% of the cases can be unilateral. There can be generalized lymphadenopathy with bone marrow involvement is there. CNS involvement is in 30% of the cases of testicular lymphoma, there is a CNS involvement. There's a high rate of CNS involvement in testicular lymphomas, especially the diffuse B cell type. Lung involvement, muscle lesions, as we saw in the PET, can also be there. And there is a good response to chemotherapy. What is against is, we have lung involvement, but miliary nodules is not the characteristic involvement for a testicular lymphoma. The other things that we're saying, the most common is the germ cell tumor. In this age, there's a rare variant, the spermatocytic seminoma of testis. Now in this variant, your tumor markers can be negative, AFP and beta HCG, which you might see in the other germ cell tumors. It can be negative in this one. It typically occurs in older men, and it has a good prognosis. What is against it is it's rare, it's not very common, and 77 is again for this is on the higher side. Again, in our nation, we always have to keep tuberculosis as a possibility. We were always taught that when you come across something rare, think about a rare manifestation of a common disease than a common manifestation of a rare disease. So definitely TB still has to be considered. Even though the sputum AFB and PCR has come negative, we still want to consider that. So patient has fever, long-term steroid use is there. There's miliary lung nodules, testicular involvement, bone marrow, lymph nodes, and we realize there can be a low yield of the sputum, and there can be a good response to treatment if it turns out to be TB. We also think about the other infections, brucellosis. We don't have any history of use of unpasteurized milk, or was he in contact with animals, was he on a farm. The other thing, Mycobacterium avium complex, the infections in the immunocompromised histoplasmosis, coccidioidomycosis. It's not very common in our region, but now there have been case reports coming up of these infections being found, and also cytomegalovirus. What is against is this patient has been having more than 5 weeks of fever with a disseminated disease, but he does not seem to be that hemodynamically unstable, going over 5 weeks. Especially again, if you think of these conditions, if you think of melioidosis, having a disseminated disease, over 5 weeks of fever, and not having any hemodynamic instability makes it a little less likely. And also there is a florid lymphadenopathy that is seen throughout. And again, testicular swelling, just as an orchitis localized lesion is less likely, rather you'd usually have a epididymo-orchitis. Sarcoidosis, again, all the multi-system involvement, florid lymphadenopathy, mediastinal lymphadenopathy, CNS involvement, all can be seen in sarcoidosis. However, testicular involvement is not so common in sarcoidosis. ACE levels, it's not critical, it's not absolutely necessary that you need to have high ACE levels. It's seen in 70% of active cases, but sometimes your ACE levels can be negative, can be normal. So my final differentials, I still put it as primary testicular lymphoma, diffuse large B-cell lymphoma, stage 4B with B symptoms being fever. The second thing, disseminated tuberculosis needs to be considered. Maybe a rarer germ cell tumor like spermatocytic seminoma of testis with metastasis. Maybe some of the opportunistic infections like histoplasmosis, coccidioidomycosis, or CMV, and also to consider sarcoidosis. No, it's always at the CPC that we realize that we clinicians are blind without the help of our pathologist friends and our radiologist friends and our microbiologist friends, and we realize that how much we need their help to clinch the diagnosis and go forward, and that is all part of a teamwork. So moving ahead, I'd be eager to know the biopsy report. How did the biopsy turn out? And along with the line of my diagnosis, to have a immunohistochemistry for further differentiation. And of course, maybe if it turns out to a caseating lesion, to have a CBNAT or gene expert analysis. Thank you.
Now that we have heard from Dr. Thomas, we would like to hear the opinion of the senior faculties of Department of Medicine. Dr. S.K. Mathur, sir, what is your take on this case?
Good morning, and I should congratulate Dr. Thomas for his masterly presentation, very calm and clear, and and I congratulate for that. And he has covered almost everything. And can I ask something? What is this patient? What is his profession? He was a farmer. And where was he from? You don't know. Okay. Then my approach for this patient will be quite different. not very different, same as he said, but I can see Arun smiling. And my, my thing is that this patient, I really feel sorry for this patient because he was managed rather unscientifically, and initially I would call it outrageous. He survived only because he came to BCMCH and also because he got admitted in a very academic unit. Then why did I say that it was unscientific? In the first place, his multiple myeloma was never confirmed. And he was started on thalidomide without any precaution. With thalidomide is, I would call, is rather a dubious and an old drug. It was invented before my birth. It is a Swedish-German drug, and then later on it was banned in India. So I can attribute almost all these clinical features to thalidomide toxicity. Dr. Thomas did not mention about stroke. If the patient got admitted to the hospital for stroke, and thalidomide therapy is well established with stroke. Many of the multiple myeloma patients, even children, got stroke after getting thalidomide. And thalidomide can cause blood clotting abnormalities and cardiac rhythm abnormalities. So initially, this patient might not have needed thalidomide at all, and he got toxicities of thalidomide. Then he got infection. Definitely a patient who is on thalidomide will get infection because thalidomide will suppress the bone marrow. He can have neutropenias, leukopenias, and he will get infection. He got multiple infections. And the second thing is that he was bombarded with all sorts of high-end antibiotics. GCS's friend and a great professor, Dr. Chandrasekhar, in his first webinar, which I happened to attend, told that Indian doctors have got a tendency to shoot the organism as soon as it is detected with all kinds of antibiotics. So this patient received all high-end antibiotics, polymyxin, colistin, ceftavi, and whatnot. Then ultimately he came to BCMCH, and then we went on meticulously. Then the third thing is that he had all kinds of antibiotics again. He continued to have fever. Then we suspect something in the background. Some other problem he is already having, which we are not able to find out. That, of course, Dr. Thomas has gone to the details of so many things. But then the most important thing happened here was the treating unit stopped thalidomide. Of course, with the concurrence of the hematology department, they stopped it. I think that is the best part of it, and that was the first thing to the road of recovery. Then I'm thinking that he was again on antibiotics, but one thing with thalidomide is that its immunomodulatory effect and immunosuppressive effect can last for weeks and months even after stopping the thalidomide. So this patient has got a likelihood of reactivation of so many latent infections like TB, hepatitis, or whatever. So my opinion is that he had a immunosuppressive or immunomodulatory effect, and he might have had reactivation of tuberculosis. And that's what Dr. Thomas told. Unlikely to have lymphoma, because thalidomide itself is a treatment part of lymphoma. Unlikely, but I will think of a granulomatous pathology in this patient, TB, sarcoid, toxoplasma, or even syphilitic gamma, and also other inflammatory and granulomatous conditions like, as you already mentioned, sarcoid. He has gone to the entire list, and I will hand over the and thank you for the Quest team to invite me to this august and scholarly group, and I thank you for that. Thank you.
Once.
Thank you, Thomas Jacob, for the wonderful presentation, and he has discussed in detail. Like Dr. S.K. Matthew mentioned that thalidomide is a notorious agent to produce fever lasting many weeks. Thalidomide can remain in the body quite a long time. But after stopping the thalidomide, also patient continued to have fever. All the culture reports may be a asymptomatic UTI, catheter-related UTIs, and false positive culture reports in the blood. That may be the reason. One thing we can come to conclusion: this is a long-standing disease which have had this having these lesions on the lung. If you analyze the LFT, you can find that there is a transamnitis. There is gradually, if you look at the liver functions, you can see that there is a AG, not reversal, equalizing the AG. There is some immunoglobulin is producing. That's also very significantly probably going to reverse it. And then if you check alkaline phosphatase, gradually alkaline phosphatase is steadily going up towards upper level. And renal involvement as well as anemia, this are all such a multi-system involvement of a disease possibility. In Indian context, always we think of tuberculosis, but may not be a tuberculosis. And in second possibility is a sarcoidosis. Sarcoidosis can present like this, and a fungal infection. So here the pitfalls which I wanted to highlight is we should have done a galactomannan, which is a fungal marker, we should have been done earlier, and that should give an idea regarding, even though it is 100% not sensitive and specific. So another thing, important thing, it could have been done a bone marrow. If it is a disseminated, if it is a picture is a tuberculosis, a bone marrow will give you easy clean diagnosis, instead of, because you said if it is a disseminated. So, or a transbronchial biopsy should have been initiated because of the nodes which is giving a clear-cut picture. So it is a multi-system disease. Probably, if one thing, disseminated tuberculosis may not be right because by the time it should have been fatal to the patient because of the fatality in the miliary rate. Then sarcoidosis and a fungal, disseminated fungal infections.
Dr. Prash.
Thank you, Dr. Thomas, for the meticulous, excellent way of presentations. Right. We clinicians, we always depend on New England Journal of Medicine. So when the journal comes first, my choice is not to look for the review article. First thing I look always the CPC. പണ്ട് കൊച്ചിങ്ങളെ ചെറുതെ പഠിക്കുമ്പം ഈ മനോരമ അയച്ചപ്പോൾ വരുമ്പോൾ ആദ്യം നോക്കുന്ന ബോബനും മോളിയാണ്. അതുപോലെയാണ് ഈ ജേർണൽ കൈ കെട്ടിയതിനാൽ ആദ്യം നോക്കുന്നത്. One thing we'll feel great because we see that very great teachers making mistakes on this. So we feel also great sometimes. Excellent way of presenting of this English, thank you. But when I saw this for me, I wanted to one thing, whether the steroid was discontinued? Oral steroids? Okay. But when you discontinued when the patient was started here? Was he on steroids when he was in the hospital? Okay. Okay. When I initially thought it was probably, I thought it would be simple. Why? Of course, I took it two way. One is myeloma, right? Second one is a high occurrectomy. That means definitely we'll do hyoectomy only in case of a testicular tumor, malignancies. So regarding when both the clinicians, we think PO as four things. One is a classical PO, neutropenic PO, HIV associated, hospital acquired pneumonia. So you put it as a classical PO. For classical PO, we always equal two things. One is malignancy. Among these is commonly always lymphomas. Second one is tuberculosis. So these are two different diagnoses we thought when we initially planned. But when you go for the neurological and the altered sensorium, I thought probably be a LMM, leptomeningeal myelomatosis, which will be usually responding. You give a steroids and the patient comes out and just walks off. So that is how initially I thought. But when you discussed detailedly, my turn called, I agree to Professor S.K. Matthew sir and also Dr. Movagis for things. Thank you for the presentation.
Thank you, Dr. Manju. Thanks, Dr. Thomas. Many people feel, there's a proverbial different people feeling the different parts of the elephant and giving their vivid descriptions. I would add my bit to the vivid description of the way how see this elephant. This patient has had a protracted fever. There are a few things that I would have liked to have more. I would have liked to have an ophthalmological evaluation because that would give a window to what is going on inside the body. That I think it was done. It wasn't mentioned. Thank you. The other thing in the CPC would have been the retics. That hasn't been mentioned. This patient has a single cell lineage deficiency in the form of anemia. He does have a low serum iron and a TSAT. However, we would have expected a TIBC to go up in a pure iron deficiency anemia. Here his TIBC is on the lower side, lower than what is expected. Is it a case of a chronic inflammatory process that is going on that has lowered the TIBC? Now, he had presented with a right shoulder pain. That was a severe inflammatory process as far as your description of goes. However, in the FDG, there is no increased uptake mentioned in the shoulder. So that is one thing that I would have liked you to clarify with the radiology. Degenerative, but also in sarcoid, you can have a degenerative arthropathy there. Facetal. That is one thing. Not in sarcoidosis, sorry, in brucellosis. There's no uptake in the shoulder. So there is no active inflammation there. That is it. But all the same, why should he develop a degenerative arthropathy in the shoulder rather than the other joints? That is the question. There's something that doesn't add up. So this gentleman has a cystitis and orchitis as per your investigations, and he has also an appendicular arthropathy, I would put it as. He has an AKI which has resolved, and hepatitis, whether it's a granulomatous hepatitis or no, not only other matters would give us further information regarding the there is evidence of inflammation because of a low TIBC and bone marrow reactive hemopoiesis showed by an increased FDG uptake. There is also encephalitis. The renal failure has improved with the ongoing measures or treatment. So we are landed up with a chronic inflammatory condition, whether it's an infective or a non-infective. My diagnosis is not necessarily going to be right, but I would like to shed light on some things that may have been overlooked, whether it's just an inflammatory process that could explain all this, the lymph node enlargement, the inflammation in the joint, the hepatic renal involvement, the diffuse enlargement of the lymph nodes. Is it something like a necrotizing lymphadenitis? Number one. Your diagnosis of a lymphoma and everything is taken into consideration, but without an active treatment, I would not have expected the renal failure to resolve. Number three, neither would have, if it was a sarcoid, which definitely would explain some of the things, it would not have resolved. So my first diagnosis would be a necrotizing lymphadenitis. My second possibility I would still like to entertain is an infective condition like brucellosis. Regarding the other things, would be lower down in the order, and this would be my take on the case. I could well be wrong. I could be just seeing a part of the problem, but I think the pathologist will have the last word, because in discussions with my wife always says, you physicians always give your differential diagnosis 1, 2, 3, 4 to 7. And it's we pathologists who give you the final word. So my wife has the final word, and the pathology department is staffed overly with women, and I think they'll have the final word. Thank you.
This patient was being treated as a case of multiple myeloma from an outside center. Dr. Akash, we would like to know your opinion regarding the possibility of myeloma in this patient.
Good morning, everyone. when the medicine department included us in the care, it was initially to decide whether to stop thalidomide or not. So the patient was obviously in sepsis, and that was a clear decision to stop the thalidomide. Then we went back to the history as to find out that the patient has been on thalidomide steroid since last 7 years. And we spoke to the patient, to the son who was there, and so this was a very independent gentleman. And son is like, he's never included us in any of his hospital visits. He goes to the hospitals, and he's been told that he has multiple myeloma. When we tried to probe, there was no history of any bone marrow aspiration ever done in this patient. But the patient has been on weekly steroid and thalidomide. If this was a case of multiple myeloma with just steroid or thalidomide, it's unlikely for the disease to remain in remission over the last 7 years. So it's unlikely the diagnosis of multiple myeloma. It is quite possible he might have had a smoldering myeloma or an MGUS to begin with, and we don't know about the treatment being initiated in this regard. At this point, again, if you look at the end organ damage, so this anemia, it is, as pointed out, there is an iron deficiency in the background of anemia of chronic disease, what it looks like. Renal dysfunction is because of the sepsis and the antibiotic use which recovered, so that is unlikely to be because of the myeloma. There's no hypercalcemia. The PET-CT did not show any lytic lesions as well. So it's unlikely that the patient has an active myeloma at this particular stage. So in our idea, myeloma was lower down, and when the PET showed a lesion in the testis versus the bone marrow, as sir pointed out, why didn't we go ahead with the bone marrow? We wanted a diagnosis in this regard, and I think because SUV was maximum in the testis, we thought the diagnosis would be easier if that was targeted. And given that the patient has been off of treatments in the last 1 year, I am guessing he's been off of thalidomide and steroid, and there's not been any progression in the multiple myeloma. We questioned the initial diagnosis of myeloma, and possibly he might have had a pre-malignant, an MGUS or a smoldering myeloma, which might progress to a myeloma in a later stage, but at present there's no evidence of an active myeloma in him.
Dr. Gino was a surgeon who did the high orchidectomy. We would like to know what were the differentials you considered after seeing the PET reports.
Thank you, ma'am, for inviting me for the discussion. And it's a long time since I had been in a medicine discussion. And also, Jansi ma'am had given me strict advice that the final diagnosis is a very classified information, and we should not mention about the final diagnosis, and only the pathologist will reveal the final diagnosis. And the patient was having a fever, and he was being investigated for a fever of unknown origin, and we had multiple differential diagnoses. And actually, after seeing this long list of multiple differential diagnoses, actually I got tensed, because it's not actually this diagnostic dilemma is not what we are really used to in surgical department. We do have some dilemmas. That is most commonly it will be procedural or surgical dilemmas, and many times the diagnosis is usually evident when the patient presents with some kind of mass or bleeding, and the diagnosis is usually evident, and we are not very used to this kind of diagnostic dilemmas. And after doing this PET-CT and USG abdomen, and I think the number of differential diagnoses got reduced. And as we have already discussed, this most common diagnosis in an old patient with a testicular lesion is testicular lymphoma, and not a GCT. And with the procedure, what we usually do is a high inguinal orchidectomy. As we all know, the lymphatic drainage of the testis is into the retroperitoneum. And if we go transcrotally, the route of lymph node drainage will change, and it will get changed into the inguinal area. So we usually don't violate the scrotum while doing orchidectomy. That is why we always go for a high inguinal orchidectomy. And usually, when a patient is presenting with lymphoma, there will be a peripheral lymph node that we can easily target, usually in the neck or in the axilla or in the inguinal region, that we can easily target and go for a lymph node biopsy. But in this patient, only we had some faint uptake in the retroperitoneal nodes and significant uptake in the testis. And also ultrasound showed some lesion in the testis. So we had to go for an orchidectomy. That for diagnosis of a lymphoma, we usually don't have to go for an testicular biopsy. Usually what we do is a lymph node biopsy. But there were no targetable lymph node with a significant uptake in this patient. And the procedure was done under local anesthesia because the patient was, the general condition of the patient was very poor. And intraoperatively, the testis was completely looking normal. And on cut section, there was a gray area in the testis. And also, it was looking a little bit suspicious. And there were no other very significantly abnormally looking areas. A small area of gray kind of discoloration was there in the testis. And post-operatively, the patient was still continued to have intermittent episodes of fever, and altered sensorium was continued intermittently. And the patient was then transferred to medicine, and we were waiting for the HPR. Thank you.
Now I would like to hand over the mic to Dr. Jency for revealing the final diagnosis.
Yeah. Thank you everyone for the wonderful contribution. At the outset, I would like to congratulate the wonderful presentation done by Dr. Thomas, and I always like the way he presents it. It's like you can never sleep in his class because he does it really well, and congratulations for that. And thank you for the excellent output from the panelists, and also from our hematologist and from the surgical oncologist. So this was referred to us from one doctor called me over the phone saying, we are a little struggling with this patient with MDR UTI. Can you take over the case? And the patient was sent over. So we took over this case as just an MDR UTI. I thought I'll just change the antibiotic and it'll all be taken care of. Like he rightly pointed out, from poly B, if I change to colistin, I thought everything would be taken care of. We did finish the course of antibiotics and we stopped it, but we realized that this is something more than that. And like how we rightfully mentioned, we thought like by then the duration was going into a classical fever of unknown origin, so we decided to go ahead with the PET. The son was actively involved with the treatment of the father, so he was helping us decide which one to go by. So we thought about all these things, like because I like to discuss with the relatives what would be our protocol. Like if this is not there, then it's bone marrow. Then like we tell them in advance, this is what we are trying to do for the patient. So our first decision was to go ahead with the PET, and sure enough, it took up high FDG avid lesion in the testis. So always the teaching in infectious diseases, if you find something somewhere with a maximum yield, go for it. So that's why we decided on the testicular biopsy rather than the bone marrow. So now I call upon the pathology department to reveal the biopsy report of the patient.
Good morning all. Thank you, Dr. Thomas, for that nice presentation. Actually, as Joseph John has rightly pointed out, the final diagnosis is always from the pathologist. So we are here to discuss the final diagnosis on this case. My postgraduate, Dr. Rekha, will be presenting the case.
Good morning all. Myself Dr. Rekha, pathology resident. So today I'm here to present the histopathological part of this case. We received a left testis high inguinal orchidectomy specimen, hole measuring 7 into 2.5 into 1 centimeter, and the spermatic cord was measuring 6 centimeter in length and 0.5 centimeter in diameter, and the testis was measuring 2 into 2 into 1 centimeter, and the epidermis measuring 1.5 into 0.5 into 0.5 centimeters. These are the gross pictures. And the cut section showed pale white areas in testis and epidermis. Coming to the microscopy, sections from testis showed lobules of seminiferous tubules exhibiting multiple granulomas. Here we can see multiple confluent granulomas were seen, and areas of necrosis was also identified with multinucleated giant cells. This is a high power of necrosis showing the necrosis, and the granulomas were composed of long elongated slipper-shaped cells. These arrows are pointing the epithelioid cells with a vesicular chromatin round oval nuclei and abundant pale eosinophilic cytoplasm. Yet another picture of epithelioid histiocytes. And special stains such as AFB stain and PAS was done. AFB was negative and PAS was also negative. So in this point, the morphological differential diagnosis we considered were tuberculous epidermoorchitis, brucellosis, sarcoidosis, and fungal infections. So first, brucellosis. In brucellosis, we get non-necrotizing type of granulomas, and it will be rich in plasma cells. So in this case, we got necrotizing type of granulomas, so we excluded the brucellosis. And next was sarcoidosis. In sarcoidosis also, we get non-caseating granulomas. So we ruled out the sarcoidosis. And next was fungal infections, such as histoplasmosis, where we get the caseating type of granulomas and also fungal elements that will be highlighted by special stains such as PAS or GMS. So this is a picture showing histoplasmosis where the fungal elements are highlighted by GMS stain. There's a gomorium methamine silver stain showing the fungal elements. The yeast budding is as highlighted as black in color. So in our case, we have done the PAS test which turned out to negative. So we ruled out the fungal infections also. And finally, the tuberculous epidermoorchitis, where we get the caseating granulomas along with multinucleated giant cells. So the morphological features of our case was favoring granulomatous epidermoorchitis, tuberculous epidermoorchitis. Thank you.
So when Dr. Gino called me from the OT, actually as soon as he finished the surgery, he had called saying, ma'am, this looks more like caseating granuloma. So we did send all the tests upfront for TB also from there. TB, we had sent a TB panel to the microbiology. So AFB smear, later on the culture, and the TrueNat negative. But it didn't finish there. So we were taking over the patient back from him, and we were thinking about starting antituberculous therapy. That's when we noticed that he's gradually going into altered sensorium. So we were wondering, and that was the time, if you realize, in between he was doing okay. He was not very febrile. He keeps having at least one episode of fever every day, probably a low-grade fever. And we thought, is the next set of UTI coming? And that was when the MDR Klebsiella was isolated. And we thought, is it like a febrile delirium which he's going into? We waited for 1 or 2 days, and we thought, no, it may be part of the disease. That's when we decided to go ahead with the MRI of the patient. So I call upon Dr. Danny to discuss the MRI findings.
Good morning, all. So the elephant in the room has come out, isn't it? All right. So to begin with, so my life is black and white, and it's purely black, white, and gray. Okay, so almost all images will be like that. You can focus on these images. These are MRI images and sequences taken. These are the plain MRI sequences. T1 image, T2 image, and flare images. You see absolutely nothing. It's a pretty normal case. Thankfully, the pathologist came to a diagnosis, so we were blessed. Okay, so thankful to that. If you ever see the clinical reports which we get really good clinical diagnosis, and then the amount of tensions we go through. But thankfully, this time the diagnosis was already given by the pathologist. So again, I'd like to thank Elizabeth ma'am for that. And then we did a contrast study on this. Now what do you see? I showed you the plain images. These are the plain MRIs. Okay, nothing. Absolutely nothing you see. But when you go to contrast, you can see where the arrow is pointing out. In simple layman terms, these are all tiny enhancing lesions. And you can see multiple of them, isn't it? Okay, These are post-contrast T1 weighted images. You can see multiple tiny enhancing lesions. And this is a flare contrast, and in that you can see meningeal enhancement. So this diagnosis is always pointing towards, when you see multiple tiny enhancing lesions, we have to think of tuberculosis. So this was our diagnosis. We have multiple tuberculomas. Okay.
So put together the biopsy report and the MRI report, we decided to start on anti-tubercular therapy along with steroids. Patient's sensorium improved, patient became afebrile. It took a while for him to leave the hospital. We discharged the patient. So regularly the son was coming back to us to tell about the condition of the patient. But we were still wondering whether it's all just TB or do we have, because always to get that microbiological diagnosis would be the gold standard for that. So 2 weeks later, we got the report from government, because the tissue, as a practice, we send it to government also. So they had done line probe assay, which picked up Mycobacterium tuberculosis. So finally, the diagnosis was disseminated tuberculosis with epididymoarchitis, retroperitoneal lymphadenitis, multiple tuberculoma of the brain, and there was one more lesion sitting in the serraceous anterior. We didn't separately biopsy it. We don't know if that also was tuberculoma. So finally, we could have a 100% diagnosis with that. So my take-home message would be, whenever we, like in this case, when the PET was done, everything was pointing towards malignancy. And for us also, the first DD was lymphoma, primary, looking at the age of the patient. So when I handed over the case to Dr. Gino, my thought process also was, first was testicular lymphoma. So sure enough, if I was in Thomas's shoe, even I wouldn't know, without knowing the biopsy and the MRI report. So he should make it. So it's a request for me to the surgeons in this room that even if the suspicion of malignancy is very high, please take a tissue sample in saline and send it to microbiology also, because later, because these are the tissue, it's gone. After we don't have a chance to go on it again and redo the microbiological study, because once it's put in formalin, we have a dead tissue there. So upfront, and I have 2-3 more of cases like this. My radiological report said high index of suspicion of lymphoma and finally turned out to be tuberculosis. So upfront only make it a practice to take a tissue and send it for microbiological diagnosis also. In this case, if we didn't get a diagnosis, we would have gone ahead with bone marrow also. Thank you everyone for coming for this quest and encouraging us also.
Our unit, and that is a policeman from the Alleppey. He had a similar presentation and a very serious illness, and he treated and went home back, and he rejoined the duty as a policeman in Alleppey. So this is just to remember that this is the uncommon presentation of a common disease is common.
Thank you, Mohan. I'll just take 5 minutes more because this is a great day for me, seeing something of this. Dr. Prashant, you'll agree with me. To have something of this high quality, and this should actually be sent all over the country. And as Dr. S.K. Matthews said, it was beautifully identified and well handled by a very academic unit. Thank you, Jensi and Anil, and all of you. Thank you, Manju. Thank you for identifying the problem and creating a CPC out of it. So this is something that we have the strength because all of us are working together. But I want to tell you a couple of more things. This man who presented so well, I discovered him at a prayer meeting. Okay? He was languishing somewhere in Tiruvalla after having had worked for many, many years in the mission hospital. So I invited him. I said, Thomas, would you consider joining us? So thank you, Thomas, for joining us and for doing such a fantastic job. And Jensi kept telling me that he is a find. And I feel proud today that I found him. I say this partly because all of you can find gems like this around you, catch them and bring them here. Second is to have a star galaxy of professors like this. I feel very excited and proud. Can we give them a big hand, including the beautiful ladies sitting there, all of them, the pathology, microbiology, and all that. And of course, for this high quality CPC. Thank you for planning it. Yesterday was a red letter day in the history of believers because we were acknowledged yesterday as a partner with Christian Medical College, Vellore. And they posted the first DM pediatric hematology. Her name is Minu Lucas from the batch of 2006, Kottayam Medical College. Sir, you would have taught her. And it was wonderful to have her. Following that, there have been a lot of other requests from CMCI saying whether they could come here and join us. Raju Titus Chaku, the former head of oncology, Abu knows him well. He is planning to join us in November. So big things are happening. But along with that, CMC has offered a 6-month posting for our DRNB nephrology candidates. We haven't got it yet. But for the application, you need a certain number of renal transplants. So Rajesh and Gio and Arun thought this, discussed with the principal of CMC, and they have accepted us as a partner. And our DRNB candidates will go for 6 months to CMC so that our program can become successful. And finally, the principal himself will be our chief guest tomorrow at our college day function. One little difficulty, 2 difficulties actually, I just want to quickly use this forum to share. One, the ARCA AI and our HIs, everything is working out beautifully. But one thing they've requested us is that all of us have come from very different backgrounds. So the history we take is all different. So Thomas, you are very good at writing and documenting. Can I request you to lead us in this? We need a uniformity in our history taking so that we'll have to discuss with them what exactly they want, and then we'll have to make sure that we have a small workshop so that we'll be able to have a uniformity in the way. And finally, the one that Danny pointed out, when they get our requests, if we could write a little more, it'll be so much easier for them. But thank you, this was fantastic. Just 2 more minutes, I'll request Jacob to introduce some beautiful people to you.
Thank you, sir. I wouldn't say I understood everything, but every moment I was getting goosebumps on and off. What an erudite gathering and what an amazing day this has started out to be. Meraki, the happiness point for Believers Church Medical College and Hospital. And it's a great privilege for me to welcome new faculty to our Believers Healing Village, something which Sir has envisioned over the years, and it's happening right now, unfolding in front of our eyes. So just like a mother would welcome her newborn, it's always a privilege for us to welcome newcomers to our institution to experience love and compassion. So may I welcome Dr. Naveen in critical care, Dr. Dan Matthew Luke. Can you please come forward, dear friends? Dr. Dan Matthew Luke, critical care again, son of our dear Luke sir. Dr. Kartika S., obstetrics and gynecology. Dr. Prashant, general medicine. Dr. Malini Ajayan, endocrinology. Dr. Bella, GI surgery. And Dr. Minu Lucas, clinical hematology. As we welcome this constellation of our new stars, can we give a big round of applause to all of them? Dear sir and dear friends, we welcome you to our institution. It's a great privilege to have you with us, and we are honored. Thank you. Thank you.